Hello, and welcome to today's webinar, Tailoring Outreach for the HCH Field, which was made possible by a grant from the Health Resources and Services Administration, Bureau of Primary Health Care. My name is Melissa Da Silva, and I will be serving as your moderator for this one-hour presentation, which will include Q&A in the last 10 minutes. At any time during the presentation, you may type your questions for our presenters into the chat box below the presentation slide. Note contact info for Ben Rock if you encounter any technical difficulties. You may call him at our office 615-226-2292. The PowerPoint and the recording of this presentation will be posted on our website within 3 business days. Outreach is the entryway to services and safety that otherwise might not be available for some people experiencing homelessness. It serves as the crucial link between the streets and HCH services. Outreach is both a key component of the HCH model of care and a program requirement for 330H funded health centers. This webinar will review the National Outreach Guidelines for Special Populations, discuss outreach as a program requirement for HCH providers, and offer best practices in outreach. Our presenters today are Alexis Walensky. Alexis is a project manager at Health Outreach Partners in Oakland, California. She provides training, program consultation services, and information services to community-based organizations and health centers so they can provide effective outreach services to underserved populations. Ms. Debian Fletcher-Blake, also a council subject matter expert and TA coordinator, is a family nurse practitioner with over 15 years of experience in clinical practice and administration. She is currently the Assistant Executive Director at Care for the Homeless in New York, where she oversees the agency's care operations. Dr. Jim Withers is the Medical Director and founder of Pittsburgh's Operation Safety Net and the Street Medicine Institute. He began his outreach by dressing as a homeless person and partnering with street-savvy, formerly homeless individuals to make nighttime street rounds in Pittsburgh's alleys and bridges. Operation Safety Net has been recognized as one of the nation's first targeted full-time street medicine program. We're honored to have his experience in today's presentation. And with that, I turn the mic over to our first presenter, Ms. Alexis Walensky.
Thank you, Melissa, and thank you for having me on this webinar. Again, my name is Alexis Walensky. I'm with Health Outreach Partners, which I will call HOP. I'm here to talk about the National Outreach Guidelines for Underserved Populations. We consider the National Outreach Guidelines to be the gold standard for outreach to underserved populations. So before we get into the guidelines, I want to first talk a little bit about what outreach is. We define outreach as the process of improving the quality of life for underserved populations by facilitating access to linguistically and culturally responsive services, providing health education, helping underserved populations become equal partners in their care, and increasing the community's awareness. So what we call outreach is very broad. It does include enabling services, but it also includes other services such as providing care outside the traditional health center walls. People who do outreach go by many different names and could have different roles. They could be community health workers, promotoras, application assisters, case managers, doctors, nurses, social workers, or physician assistants. So why do outreach? Outreach fulfills a critical need to increase access to services and reduce health disparities. It helps organizations fulfill their mission, and strong, sustainable, community-based outreach improves the health and well-being of individuals, communities, and organizations. So I want to talk a little bit about the history and the background of the National Outreach Guidelines and how these guidelines came about. After about 30 years of providing direct outreach services to migrant and seasonal farm workers, Health Outreach Partners began providing capacity building to community-based organizations. These 30 years of experience was the basis for the Farm Worker Outreach Program Guidelines, which formed a sort of skeleton for an effective, comprehensive outreach program for migrant and seasonal farm workers. And this was a little bit over 10 years ago that these farm worker outreach program guidelines were developed. By 2012, HOP had expanded its scope of services and led the effort to leverage various organizations' experience as a basis for creating universal guidelines for outreach across underserved populations. So HOP partnered with 4 other community health technical assistance organizations, one of which was National Healthcare for the Homeless Council. And these partners provided a vision for the guidelines and also contacts at the local level for an advisory panel. So the advisory panel represented 18 members in 14 states throughout the country. We involved representatives from across the spectrum of special populations, and the advisory panel members were from community health centers and other support organizations that provide direct services and have close ties to the community. They had outreach experience and an on-the-ground perspective. And they attended an orientation, completed a questionnaire, and participated in phone interviews and informal focus groups. The result was the National Outreach Guidelines for Underserved Populations. These guidelines are a resource that is available to support programs in planning and evaluating their outreach activities to special populations. It's important to note that the National Outreach Guidelines and their strategies always need to be customized to each organization and community. So we use these guidelines as a springboard. As technical assistance providers, we work with organizations to figure out which strategies work well for their specific community and in the context of their specific organization. The guidelines are not exhaustive or prescriptive. They have to be customized. And even though we consider the National Outreach Guidelines to be the gold standard for outreach programs, we recognize that not all organizations can or want to fulfill all of the guidelines. There might be funding, staffing, or other limitations, or there might just be other organizational priorities. So what are the guidelines? There are 3 elements, 3 levels to this pyramid, and these 3 levels represent the 3 elements of a comprehensive outreach program. So at the top we have people, in the middle we have community, and at the bottom we have program. And there are guidelines that are associated with each of these different levels. So within the person focus at the top, we have helping individuals and families access care, providing health education, providing outreach-centered case management, behavioral and mental health support, doing clinical outreach, which could be a whole spectrum of services ranging from basic screenings and outreach settings to actually providing primary care in a variety of locations where the population you're trying to reach is located. And lastly, for person-focused, we have public benefits, eligibility, and enrollment assistance. So that's the person-focused guidelines. Next, we have the community-focused. We have community-based outreach. And this may sound like a no-brainer for many people that outreach should be happening in the community, but we heard from our advisory panel members that this really needs to be made explicit, that outreach happens where people live, where they work, where they spend time, where they congregate. So that is a fundamental basis for the National Outreach Guidelines, that outreach happens in a community setting. Next, we have advocacy on behalf of underserved populations and community collaboration, so actually forming coalitions or partnering with other organizations and service providers within the community. And finally, under program focused, we have program planning and evaluation. And this is really the foundation for a solid outreach program. Each guideline comes with a number of potential strategies for addressing the guideline. We unfortunately don't have time to go into every single guideline today, but we can talk for a little bit about one specific guideline. And if you go to our website, we have a summary of all of the guidelines available, and you can always request the full National Outreach Guidelines, which include all of the guidelines, the visual model, as well as associated strategies for each guideline in a document. So I'm going to talk a little bit about one particular guideline, which is our Behavioral Health Support Guideline. It's a person-focused guideline on behavioral health, and it reads, the outreach program will coordinate access to behavioral health services and provide basic mental health support for underserved populations. The photograph that's on this slide is from a music therapy outreach program for migrant farm workers in western North Carolina. And this music therapy program took place in migrant camps. And it's an example of how this guideline has been customized in a culturally responsive way for the population the outreach program was trying to serve. So this outreach program was reaching out to migrant and seasonal farm workers in western North Carolina, and an effective way that they found of doing this, of providing behavioral and mental health support, was to call these music therapy sessions music classes, and provide a support group in that particular way. So we have many other examples of innovative outreach practices like this available on our website. If you go to Health Outreach Partners website, we have an entire database of innovative outreach practices that are examples of how these national outreach guidelines can be implemented. So the next three slides highlight some possible strategies for fulfilling the behavioral health guidelines. These strategies came from the National Advisory Panel that worked on developing the guidelines. And again, these are not exhaustive or prescriptive. We don't suggest that every program has to do all of these, but they're just ideas to help support programs in developing strategies that work in their own particular context. So some of the suggested strategies for this behavioral health support guideline include making sure that the people that are doing outreach attend training in order to be able to identify common behavioral health needs for the population that they're serving, and being able to make referrals as appropriate, encouraging members of underserved populations to practice self-care and positive coping skills, facilitating the development of peer support groups that promote general well-being and decrease social isolation. We have some additional strategies, destigmatizing mental health issues, promoting awareness, educating individuals and families about behavioral health services by describing the services that are available and their benefits and what to expect. And then I think one important role that outreach programs often provide is to educate other providers, other service providers that maybe aren't doing outreach or aren't that aren't providing their services in an outreach setting, is to educate them on the barriers that underserved populations face when seeking and accessing the services that they provide. So, and educating them and also working with them to find ways to minimize and overcome those barriers. So that was just a very quick introduction to the National Outreach Guidelines. We sort of breezed through them, but we do have a summary available on our website, as I said, and you can request the full set of guidelines and strategies by going to the Health Outreach Partners website. You can also email me. My contact information is up on this slide. We've worked with many health centers to develop and assess their outreach programs, and we often use the guidelines in our training and consultation work with community health centers and with primary care associations. So please contact us for any assistance with applying the guidelines to your own program. And I went through that quickly, but hopefully that will leave more time for questions at the end. So thank you again for inviting Health Outreach Partners, and I'll turn it back over to Melissa.
Thank you, Alexis, for that highlight on a critical aspect of outreach for our community. I'd like to turn the mic over now to Ms. Debian Fletcher-Blake, who will offer us an administrator's perspective on outreach for the ACH field, and a reminder to our participants to type your questions for our presenters into the chat box at any time. We'll be getting to Q&A at the end of Dr. Withers' presentation, so within the last 10 or 15 minutes of today's hour. And with that, Debian?
Thank you, Melissa. Thank you, Alexis, and thank you for having me on this webinar. There is new energy around healthcare and healthcare practices, and we have the Affordable Care Act to be thankful for that movement. Therefore, it is important that outreach is looked at from an Affordable Care Act perspective, and that is what I will try to do this afternoon. From this session, one will be able to demonstrate the role outreach plays in accomplishing the Affordable Care Act's triple aim objectives, also understand the challenges and opportunities of outreach in a Healthcare for the Homeless program, and understand how to develop an outreach strategy to meet new healthcare demands that will be brought on by the Affordable Care Act. So let's look at the Affordable Care Act for a minute. Under the Affordable Care Act, states have the option to expand Medicaid eligibility to its citizens. It extends eligibility to single adults that are at or 138% below the federal poverty level. So to put that in dollar amounts, a single adult who makes $15,000 annually, or a family of 3 that makes a shade over $25,000 per year will benefit from Medicaid expansion. Medicaid expansion is extended to the childless adult, also called childless adult expansion. So what are the requirements? Patients are required to be United States citizens or legal resident for a minimum of 5 years. And this is very important for the patients that we see in our practices. Let's talk about enrollment and what we can expect when we are doing outreach. Currently, approximately 60 million people are enrolled in Medicaid. But by 2014, that's a year away from now, the Congressional Budget Office predicts an additional 13 million people will be enrolled, and CMS predicts 18 million people. That will amount to about 13.4 million new enrollees. That's a lot of people that will be enrolled. The good news is there will be no need for asset tests that we are accustomed to. There will be more efficient and timely determinations. Lucky for our patients, there's no need for a permanent address. There'll be a 12-month automatic renewal and electronic verification of income and identity. All these combine to make the process very simple for outreach. So once patients are enrolled, care coordination becomes simpler, and the goal of enrollment is care coordination. If we can coordinate care, then we can definitely impact care. But there are things that are necessary. We must understand the population that we are treating, that we are serving. There has to be an accountable delivery system, and at the center of that delivery system, there must be outreach. There has to be transformation of the delivery systems that we are accustomed to so that we can meet the needs that are set forth by the Affordable Care Act. Outreach must be a focal point of every delivery system that we put in place. With the Affordable Care Act, outreach involves more than outreaching to the patients, and I'm glad Alexis had that in her slide. Excuse me, Alexis. We have to identify gaps in care and identify necessary resources to get services to the patient. The patient becomes the hub, and we outreach for services and bring the services in so the patient can get comprehensive health care. So why is outreach important? Outreach engages patients that are not enrolled in health insurance. The Congressional Budget Office estimates there are 21 million should be enrolled by 2016. However, 30 to 50% will be eligible for enrollment but will not be enrolled. 30% will be undocumented and therefore, as you know, not eligible for enrollment. But what is specific to us and to the patients that we serve is that majority of the people that are eligible and not enrolled are likely to be vulnerable, chronically homeless individuals that we see on the streets, that wander into our clinics, that we meet sitting on benches, and therefore we need to have aggressive outreach programs to get those people enrolled in health insurance programs. Outreach also engages and links patients to healthcare services. It is an effective strategy to engage homeless patients, as we know. It also meets program requirements for funding. For most of us, HRSA is our largest funder or significant funder, and outreach is a program requirement. Significant individual and public health benefits are seen when patients are linked to care. And that's the reason outreach is so important to facilitate the Affordable Care Act's triple aim objectives of improved health care. So outreach, in fulfilling the triple aim objectives, it increases access, improves health outcomes, and decrease costs. How does it do that? Well, if we educate patients about their benefits and eligibility, enroll them in health insurance plans, such as Medicaid, CHIP, Child Health Plus insurance, and we introduce them to competent health care, we are creating access for them. When access is created, outcomes are improved. More patients will get health benefits, and we know the benefits of being insured. Treatment for substance abuse and mental health illnesses can be maximized. And what we do know is that 68% of people with a mental health illness also have a physical illness. We will be able to engage difficult-to-reach patients into care. And when we do that, we are able to take care of their chronic medical illnesses, and then we can assign them into health homes or patient-centered medical homes where they can get care coordination. When health outcomes are improved, we decrease costs. There's less reliance on emergency departments when patients are linked to care. There's increased preventive care, which is cost-effective. We will be able to treat high utilizers in primary care settings and with care coordination. In so doing, We eliminate duplication of services, which all have a positive financial impact on our healthcare industry. It is important to look at the opportunities that come with a good outreach program and also the challenges to accomplishing a program that is effective and meets the needs of the Affordable Care Act. So let's first look at opportunities. Good outreach increases access to health care. That's the patient linkage, where we're bringing the patient into care. It increases access to specialty care and other services. That's the enrollment linkage. We're providing health insurance so people are able to access specialty and other services. Patients benefit from core services such as case management and care coordination. Other services become affordable because of eligibility, enrollment. There is improved health outcomes, and that is a combination of the patient linkage, bringing the patient into care, and enrolling the patient into health insurance. And very important, the health center gets increased reimbursement. There are more patients. There are opportunities for patient-centered medical home. Care is focused. There's care coordination. All this have a positive impact on prevention. But there are also challenges that we must be cognizant of. The process of outreach itself is a challenge. It has to be deliberate, and it has to be well thought out. Enrollment is a challenge. As we saw earlier in my slides, there are many people to be enrolled. So the process is going to take a long time, but we need to be moving at rapid pace. Engaging the population that we work with is a challenge. We found ways to make it work, and we'll have to find new ways to make it work better with the Affordable Care Act. Finding venues that are appropriate for care. It's the gaps in service. Where can we find appropriate place for our patients to get care? There's the capacity to provide services. How much and how many services will we be able to provide with Affordable Care Act? Fundamentally is workforce development, and I know this is an issue that a lot of people are talking about. Clinical workforce development and non-clinical workforce development. And then there is the also important bridging gaps in coverage. Not all services will be covered, even with Medicaid expansion. Services like oral health, transportation, it's all contingent on what the state decides. But we must press along, and we must find ways to mitigate the outreach challenges. One of the most important ways to do this is through staff training. We are accustomed to a system where incentives and information was sufficient for outreach, but now we need to add leaders to identify gaps in care, leaders that will be able to engage patients and to enroll them in care. And who are the leaders that I'm talking about? They include our frontline staff or providers and anyone that the patient interacts with, remembering that the patient is the hub and everyone around is the support system. Educate and involve consumers and peer advocates in the process. They are a lifeline. Use them as much as possible for outreaching to difficult-to-reach clients and for teaching clients. Give them the information and let them go out. Let them be leaders, too, in their own field. Develop community partnerships with other service providers. Use them as our referral sources. Use them as a referral to get patients into care and also to inform patients about the Affordable Care Act and to bring them into care. Solidify relationships that we already have with specialty care providers. Now more of our patients will be enrolled in Medicaid, so let's expand our relationships with them. Let's get involved with or become a medical home so that we can get incentives to leverage the outreach work that we'll have to do. Look at your capacity to provide care coordination. There may be some money involved in that, some financial incentives for you to do so. Revise your frontline staff job descriptions to incorporate your outreach responsibilities. As you transform your delivery system, think about the job descriptions that need to be changed to make the transformation possible. Strengthen your outreach capacity so that you will be able to bring patients into care and enroll them in Medicaid. So in summary, I would like to say outreach has a crucial role, and even more so with the Affordable Care Act. We have seen it work in the past. We understand how it works. And so now we just need to fine-tune what we're doing to make it part of the Affordable Care Act in our practice. And outreach is so crucial because enrollment does not mean engagement, as we know. Outreach is access to care for vulnerable populations, to populations that we're talking about today. So a good definition for outreach is provided here. It is contact with any individual who would otherwise be ignored or underserved in non-traditional settings, and you will be hearing from Jim in a minute or two about real non-traditional settings, for the purpose of improving their mental health, their physical health, or their social functioning, or increasing their human service and the use of resources. I thank you very much, and I will hand the mic over to you, Melissa.
Thank you so much, Debian, for highlighting the importance of an effective outreach program for improved outcomes in the HCH community. A quick reminder to our participants that we have a chat box below the presentation slides. You can go ahead and type your questions for our presenters into that chat box. We will get to your questions at the end of Dr. Withers' presentation. And with that, I now turn the mic over to Dr. Jim Withers.
Thank you so very much. Excellent prior speakers, fascinating. Street medicine is a natural component of what Healthcare for the Homeless has been doing so well for many years. Many of the programs have started, indeed, with work directly on the streets in addition to the work that's done in other settings, soup kitchens, shelters, etc. My personal journey into this began as a teaching physician. Actually, it began long before that. This is as a child in Nicaragua. I was fortunate to have a family practitioner father and a nurse mother. We made visits into the highlands of Guatemala, and it was so evident that all of the issues were so much influenced by the context of a person's life, the forces at work for improving their health, and then those things that were working against that. So as a medical educator, the example of my dad's horse calls here, if you will, and other experiences like that led me to really want to get where the people were, so to speak. Here again, just a background photo of work earlier as a teaching physician in Belize. But of course, we know that there's plenty to learn here within our own country, on our own streets, and it's really, I think, the way that healthcare in general needs to go is to learn ways to connect with the reality of where people are. And I think this goes across the board, but those of us in healthcare for the homeless field are very familiar with the challenges and the joys of working in a way that includes the reality of people's lives. My work is done predominantly here in lovely Pittsburgh. We have a lot of bridges. It's now a post-industrial city, but we're making a comeback. Unfortunately, there are a lot of people who, even despite the growth in healthcare and education, still find themselves left out. As you all know, health does have a great influence on homelessness, both leading to it and perpetuating it. For the purposes of our outreach, I think we can talk briefly about some of the stuff that was discussed with the work of Dennis Culhane and some of the other authors that are out there, referring that most of the homeless actually do have a fairly short duration. Those are the people that we can have an impact on quickly. But there's a remainder, which are more often those sleeping on the streets, which utilize a great deal of the resources. The people who find themselves on the street have a very fluid existence, and the definitions of homelessness, I think, are difficult to just categorize as transient or chronic. People moving between the different settings and experiences and frames of mind, actually. The street itself has this is Dr. Pat Perry's development of a model for the morbidity cycle, in which people who find themselves on the street have the issues of disability and their poverty and poor health care access, leading to worsening of their condition, poor health, and resultant hopelessness that goes with the trauma, shame, and despair of homelessness just feeds. So we find so many of our people being out there on the street and feeling stuck. This is just another Pittsburgh scene, a woman who's probably just recently hit the streets and is just making do for the night, and then other groups that are much more chronic. And in my travels around the United States, I've seen growing numbers of campsites in which homelessness for the time being is just the way it's going to be. People even organizing their campsites into ones in which there are guards and natural leaders, cottage industries, etc. So we're looking at a shift, I think, in the in sort of definition of homelessness as a larger and larger segment of our society, and we're challenged to bring healthcare, as Healthcare for the Homeless has, deeper and deeper into the campsites and the locations, the abandoned buildings where people are. And unfortunately, in the case of this gentleman, it was too late. This is early on in my street career, in which an older man died of pneumonia and exposure in this one isolated camp that he had built. To go into the streets, you need to have guides, as was stated by the earlier speakers, those from the community whose knowledge and wisdom of the streets are honored and used. In my case, this was my friend Mike Sallows, who had been homeless himself for 7 years and formed the ambassador role for me to get into the streets. And this is the two of us going out trespassing somewhere under a train tunnel here. And as you can see, the backpack is actually pretty small at this point, without a lot of supplies. I think it's sort of with the mirroring the philosophy of Craig Rannebaum. Sometimes it's better to go out and make sure that you're listening and engaging and not just bringing things to people. But being in healthcare, when we're out there, we do have to respond to the moral imperatives of the things that we see. So street work, as a special subfield, is something that most of us have to just learn by the seat of our pants. There's a growing number of individuals who have more experience in providing health care under bridges and in abandoned buildings, but still it's an area that needs a lot more work in terms of standards. This is a fellow who had lost his toes to frostbite, and by focusing on him and some of the other people who have high-risk issues, we're able to prevent further complications and medical costs and morbidity. The symbolism of having nurses and doctors and medical professionals out in campsites, I don't think can be underestimated. And there's a lot that has to do with the will that people have, the sense of being connected to the rest of society and wanting to give it another chance that I think is obviously integral to the work that we do beyond the medical expertise which we are able to bring. Trust transfer is something that I found is never to be underestimated in its importance. In a case such as this, I was able to transfer some of the trust that this gentleman had me to a psychiatric care nurse, and then we build the bridges from the street level in a process which we at the Street Medicine Institute refer to as InReach. It's walking with people in solidarity into the systems. And here is an example of myself writing a little note to tell this fellow that wasn't home that night that his doctor would see him. His regular doctor would see him again after a long hiatus. And so we've become more or less a home care service, a 24-hour home care service for the streets. And at this point, our program, I think, really began to gain significance in my mind as a bridge, if you will, between the street world and that of the general medical and social communities. So as long as there are people out there in Pittsburgh, we're going to keep going. And we'll do it on the terms that work for the clients. Patient-centered care, motivational interviewing, all these things become quite integral in the skill set that you naturally acquire. Again, many good resources at the Healthcare for the Homeless website, the outreach manual, the writings of Craig Rennebaum and others. This is a map some time ago of the different sites. So you have to begin being aware of where the homeless camps are with, again, a degree of HIPAA privacy, because these are oftentimes locations that are ones that the clients want to protect. But it's important to have a language developing for where people are and how you're going to cover those zones on a regular basis. These are all natural things that emerge in the strategy of a street medicine program. Our core staff grew, and in all cases you move. We have 3 basic developmental stages, if you will, of street medicine programs we've described. And when you start to get administration and social worker support, then you've moved into a much more permanent level than the initial grassroots level, and you're able to accomplish a lot more. In this photo, you see 3 of the gentlemen are formerly homeless, and so we always have a formerly homeless person. We're fortunate on each team. That can be someone who's not formerly homeless but has, obviously, a deep respect of the street culture and is trusted by them. A place for folks to walk in is important, where they're not ready for prime time, but you can give them the services. Often people forget to give people belts, so this is just something that is immediately useful. Backpacks tend to get bigger and bigger. This was mine at its largest. I'm debulking at this point. But it's basically just the things that you'd find in any Healthcare for the Homeless clinic in waterproof Ziploc bags. I and the other physicians have a medical bag appropriate to our degree of training. Each outreach volunteer or worker has a customized bag for them, and all of the medical decisions are passed through myself as the medical director or someone else who's on call for me. We've had an electronic medical record since 1992. It is web-based, and we're able to access our records under a bridge with our smartphones. And then we divide our work up into walking teams, and then we have a large mobile home for people that want to come to us rather than us going to them, which we call case management. But we have a philosophy that wherever there are people out there, one of the litmus tests of our work is, do we find them and engage them in ways that work for them. I'd like to suggest to those who begin this work as well that going into the hospital system, another form of InReach, is really critical. Also the emergency rooms, etc. But you bring the street culture in, and therefore you immediately have to do education and community building. Sometimes it even resembles piecework. But by providing a consult service, such as we have in Pittsburgh and in Boston and a few other places, the discharge plans that are established are more effective, timely, and more reality-based, so that we avoid discharge plans that look like this one, which we've all seen, I guess. Housing is a upper-level street medicine accomplishment in which you're able to access funds, support, if you're lucky enough to have a market where the housing is affordable, to get people into housing. You take the care team that knows them on the streets into the housing to make house calls, so that a true medical home model is one that we are now endorsing, if possible, at the later stages of development of a street medicine program. We integrate students, nursing students, medical students into our work, and in fact many of the street clinicians from the United States and overseas got the idea by rotating with us and are now changing the culture of medical education, that this is normative behavior and no longer the sort of maverick activity that I think a lot of us have been viewed as doing. This is our classroom. We learn in context, very fluid model, and it's comfortable, and it's a lot more gratifying, I think, for those who practice it. So that's the work of Operation Safety Net and our website in Pittsburgh. Briefly, I'd like to talk about the fact that, much like the Respite Care Providers Network, folks who do this very specialized work have a great desire to connect with others, to learn, to have validation for what they do, and to improve their practice and advocate for those that we serve. My networking began strangely enough in India. I was able to go to Calcutta and meet Mother Teresa briefly, and then my hero Jack Prager, who's been on the streets working in Calcutta since 1979, and continues to do so, though he's 81 years old. So I guess you could argue that there's a longevity component built into street medicine practice. But when I met him and saw his work, it really was an epiphany for me that I wasn't really alone, and that there were other folks perhaps that were had or were interested in creating models on the street. This is a similar work, and in each case I saw that the problems that I was trying to solve were ones that he had also tackled. I'll try to finish more quickly here, but suffice it to say that in cities such as Morgantown, Cleveland, Honolulu, Anchorage, Alaska, San Juan, Puerto Rico, of course Boston, Columbus, Ohio, New Orleans, Copenhagen, Denmark, Beijing, China, Moscow, and Kano, Nigeria. There's a movement afoot of practicing street medicine and connecting at our annual International Street Medicine Symposia. This is our network as it stands. We get new calls every week for folks that want the extra counseling that we can give. And we do, as I said, have our international symposia in which many healthcare for the homeless providers participate, and John Logier is always present and supportive as well. So we've grown as a subspecialty, and we have a lot of fun. We meet and discuss this. This is the only forum. We try to get out and practice some street medicine while we're at the meetings. And then finally, in 2009, we started the Street Medicine Institute to specifically support those who want to bring medical care and other services directly to their brothers and sisters that are sleeping on their streets. We have a vision that every person sleeping on the streets in this world will have access to care, and that every health science school will have a classroom of the streets. Our 4 pillars are to assist communities who are seeking to establish street medicine, to improve that practice, to build a global vision through our annual meetings, and to create learning environments for students in exchange amongst our programs throughout the world. This is our last symposium here in Salt Lake City. We're looking for our next site for 2013. We always have student involvement, which is a great source of energy. And as the streetmedicine.org website is accessible, I encourage you all to look at that, and as you build your healthcare for the homeless work, know that we're with you, and we'd like to partner further with you. Thank you very much.
Thank you so much, Dr. Withers, for that wonderful presentation and for sharing so many images of the work of outreach. I want to also say thank you again to our wonderful presenters, Ms. Alexis Walensky and Ms. Debian Fletcher-Blake. We have a question for each of you, actually, and I will start with the question for Alexis. Alexis, our participant Ian inquires, can you provide some ideas as to how a health outreach service can gather data to measure outcomes? And it's two parts. And how do we demonstrate that our efforts are having a positive impact? Alexis?
Hey, that's an excellent question. Thank you. Evaluating and measuring outcomes is a huge priority for so many organizations right now, and it's something that a lot of us are working on, and there's definitely, this is a priority for our organization, is being able to work with outreach programs to do this even better. So one thing I would definitely say is to start, if this is something that you're working on and this is new to evaluating, or you're starting a new program, the first thing I would say is document what you're doing. So if you don't document it, then in the future people will look back and won't know that it happened. So that would be the first step. Documenting is also important for the sustainability of your program and of your efforts. So so once you have a system in place for documenting your outreach efforts, then you can start connecting what you're doing to some of the things that Debian talked about, of connecting your outreach to the improved access, to improved outcomes and decreased cost. So documenting is definitely the first step. And then we recommend when you're planning your program that you also plan how you're going to evaluate it. So planning how you're going to document, how you're going to measure what you do, how well you do it, and the impact that it has. So many programs will create logic models and evaluation plans, and that's how they figure that out when they're doing the program planning process. And then some programs will actually partner with researchers, universities, or graduate students to design more formal studies to really show the impact that their efforts are having. And if you're looking for some research, some resources and some ideas about how to do this, we have an outreach reference manual on the Health Outreach Partners website, and there's an entire chapter dedicated to evaluating your outreach program. We also have a number of other articles. And if you have any other questions or want more support in evaluating your outreach, we'd be happy to talk with you about your specific situation and help you think about what are some tools and ways that you can do that.
Thank you, Alexis, for that thorough response. Note to this participant, both Health Outreach Partners and the National Healthcare for the Homeless Council exist to provide this kind of TA and training support in the development of outreach programs. And I'll get to a little bit of that in a third question, but our second question is for our second presenter, Ms. Debian Fletcher-Blake. And the question from Emily is, are there any provisions in the Affordable Care Act that provide any funding for increased outreach to vulnerable populations if and when states expand their Medicaid programs? Debian?
Thank you, Melissa. Excellent question. I knew this was coming. Each state will decide what they reimburse under the Affordable Care Act. So there's no direct provision that says states must do A, B, C, or D, but your state will choose what they decide to reimburse. It is imperative then that you align with your state officials, if you haven't already done so, to help shape the reimbursement in your state. So that's, part of the outreach that I talked about is knowing, working with your community partners, and your state officials become your community partner in this so that you can determine or have a say or a seat at the table when these decisions are being made. There are some states that have reimbursement for care coordination, and so outreach can become part of that care coordination. It's about being creative and the transformation of your delivery system so that you can benefit from the financial incentives that are there.
Thank you so much, Debian. I also want to remind the participants that if you've got more focused questions around this topic, feel free to contact us via our online TA request so we can maybe further explore your state context and offer you more targeted assistance to this question. So we have, looks like a couple of questions now for Dr. Withers. Dr. Withers, Linda has a two-part question. What is the optimal number of staff required to begin outreach to homeless populations? And that I'll pose to you in a second. And then the second part of her question is, what online resources are available for training outreach workers? So Linda, as Alexis mentioned, a HOP exists just for this request, this type of training request. We also can offer this training or TA. And we know that outreach does not look the same everywhere, and so it's not, maybe a resource is not always going to be able to give you the information you need, but know that we are available to respond to the specific outreach environment of your community. And with that, I'm going to turn back to Dr. Withers with the question, what is the optimal number of staff required to begin outreach to homeless populations? Dr. Withers?
Yes, thank you. I agree with you. Much like each person on the street is different, each community, each group of stakeholders, each homeless environment is very different. And so much like the health outreach partners in healthcare for the homeless, we encourage a one-on-one line of communication, seek as many sources as you can. We also are more than happy to come to your community and do rounds with you and have you visit one of our hub cities where we feel that there's relevant experiences to be had. So that's available. The optimum number of staff required to begin outreach, I think there's no perfect answer, but I would say probably around 4 is what I would generally think works the best for us and for a lot of the other folks that I've seen. Now, sometimes the outreach unfolds differently if it's based in a van, or if you are working in a large area such as they do in San Diego and Santa Barbara, where they have actually a lot of fun. It's almost like an open market every week or so, in which each outreach person and lots of students have their own designated roles, and that's a different kind of outreach, and it's a little more similar, I feel, than to our van model, in which people can come to that location and engage, or partly engage, or whatever level they want to those services. But when you're going into abandoned buildings and under bridges and things like that, you certainly want to have leadership of an experienced outreach worker for safety. We've never had anyone in our network assaulted seriously. No one's ever been sued successfully, and so those are just 2 things that people usually ask. I think that, of course, the folks in camps need to get permission for you to come in to the camp, so we send in our outreach worker first to discuss this, and then if we get permission, we come in. And then we always have someone that kind of watches the scene and watches everybody's back, and our formerly homeless person has the final say on whether you pull out of a particular campsite. But again, I am always open and available to talk if I'm in the country, or our staff, or we find someone that has a relevant model that's similar. The online resources, ironically, our website is down this week. It hasn't been before, but that is one of them. Healthcare for the Homeless has probably the richest source of material on this. But you could also look at a really excellent YouTube series that the Path Street Outreach videos on YouTube that SAMHSA put out that I think are actually very, very useful. There's a 3-part series of those. If you read the rather extensive Healthcare for the Homeless Outreach Manual, it really holds up quite well. And there's an article that I always loved that some nurses did in the 80s called Dancing with Grace, which should be referenced on our website.
Excellent. Thank you so much, Dr. Withers. I am going to have to wrap us up because we're at the hour. I want to thank Dharmasili, Jonathan, Susan, and Yasmin for your questions. Note that we will respond to your questions, and all of the responses will be posted with the archived recording and slides on our website within 3 business days. And I apologize that we could not get to your questions during this live webinar. I want to remind everyone that we are available for TA and training on the topic of outreach. Because there is so much mentioned about the Affordable Care Act, I also want to offer that at the end of February we will be offering a webinar on Medicaid eligibility, enrollment, and outreach, changes coming to the HCH community, which will include presenters from CMS, SAMHSA, Enroll America, and led by our very own Director of Policy, Dr. Barbara DiPietro. I also want to remind you that we have a national conference coming up, March of this year in D.C., and that will be March 13th to the 16th in D.C. Please check out our website. On the home page, you'll see links to registration at www.nhchc.org. With that, please take our survey so that we can improve the products that we develop for the HCH field. And thank you all so much for your time and attention. And thank you, Alexis Dedian and Dr. Jim Withers, for your time and excellent presentations. With that, have a terrific afternoon, everyone. Bye-bye.